This presentation on mental health related to the complex and specialized care of older adults is made available for us through the Geriatric Nursing Education Consortium. The GNEC is a national initiative of the American Association of Colleges of Nursing, and it is intended to enhance the geriatric content in senior-level undergraduate nursing courses. The project is generously funded by the J.A. Hartford Foundation. There are several learner objectives that I encourage you to read through. I'm not going to read through them for you. I'd like to move forward to slide 5, which is an introductory page. And like each phase of human development, we know that late life poses opportunities and threats to adaptation and to overall well-being. We know there are many common transitions in late life, including retirement, relocation, maybe death of a spouse or friends, some serious medical illnesses that occur, needing to assume caregiver roles, and as well as the transfer of care responsibilities for mentally disabled or ill adult children. And while most older adults can manage these transitions with resilience and hardiness and resourcefulness, there are those with specific vulnerabilities who may develop maladaptive responses and, in fact, mental illness. So people living with a serious mental illness grow old, and we know that changes associated with aging can further compromise a lifetime of challenge, coping, and thus exacerbate symptomatology and well-being. Including older adults with dementia, there are about 20% of older adults who have mental illness. And with the rapid aging of our population, we know that the actual numbers of older adult persons with mental illness will soon overwhelm the mental health system. No form of mental illness is a normal consequence of aging. None. Older adults do, however, encounter many life transitions, as we've previously stated, that are often very stressful and present challenges to their ability to adapt. Social support for the older adult is huge. It's a very important resource for their ability to cope with and adapt to these common life stressors that occur late in life. As many research findings have made clear, older people who exercise, both physically as well as mentally, do better overall. We know that physical exercise, including walking, aerobics, ballroom dancing, tai chi, etc., is very important in preventing or improving symptoms of anxiety and depression. And we also know that mental exercise has been shown to be protective of decline of cognitive function in individuals with dementia. Especially helpful are activities that tax the brain, like crossword puzzles, board games, playing a musical instrument, performing art, reading, etc. Mental disorders like depression and anxiety or cognitive loss will often exacerbate the symptoms and the functional disabilities that are associated with medical illnesses, and in turn result in an increased use of the healthcare resources that are available, including medications, length of hospital stay, and overall cost of care. Likewise, for these individuals, the quality of life is further reduced. Because older people are more likely to suffer multiple chronic medical disorders, the nurse must be on constant alert to also detect comorbid mental illness that may produce excess disability. Since depression and anxiety can be treated, thus lessening the overall burden of the chronic medical illness, it is very important for us to recognize these comorbidities and assist the older person to access appropriate care in a timely manner. While we expect a lot of changes as our baby boomers age, today's older population has been less likely to acknowledge mental illness or even to access mental health services. That's because many stigmas exist regarding the meaning of mental illness. A lot of our older adult population currently view mental illness as a sign of weakness, and they're very unlikely to admit to problems, especially when they fear their loss of independence. Many of them believe that symptoms of dementia and depression are a normal part of aging. And there are still others, especially those who live in the rural areas, who lack availability of or have no access to services that are available. And for those older adults who have access and are willing to seek and accept treatment, payment systems are typically very poor in terms of allowing for charges for mental health care. And this, in fact, has reduced the numbers of providers who are willing to accept older clients, and the number of older clients who can afford to pay out of pocket for this care is very, very low. Very few mental health providers have had specialized training in providing care for older adults, and a lot of them come with their own set of biases themselves. Some of them believe that older adults can't change, that depression or cognitive impairment is normal, and that it's too late for psychiatric care, okay? That it gets in the way of developing, and that gets in a way of developing a therapeutic relationship that's needed to help the clients get better. The older adult with mental health disorders can be found in the emergency department or in general medical or surgical units in acute care settings. All right, and they've typically been admitted with a primary medical problem, which is exacerbated or compromised by depression, anxiety, cognitive impairment, substance abuse, or some other long-standing mental illness. We know that these comorbidities add to the length of stay and increase complications. So the astute nurse who can identify underlying comorbidities early and seek consultation and treatment will best help the older adult with a timely recovery. We know that in nursing homes and assisted living facilities, there's a substantial number of residents who have mental health disorders. These typically include dementia, depression, and chronic mental illness. We also know that there's both an under and over treatment, okay, that's been documented in these settings, and that there is a severe lack of specialists who are available for nursing home mental health services. In all of these settings, the initiation by the nurse of routine screening for depression and other mental illness is very important for us to understand the baseline of these individuals and to be able to recognize changes in over time. Because of their prevalence and their impact on function and quality of life in our older adult population, 3 specific orders are going to be given focus in this module. They include depression, substance abuse, and serious mental illness. Symptoms of mental illness may not be as clearly distinguishable from symptoms of medical illness in older adults. So, special screening instruments should be incorporated into the admission and ongoing assessment procedures for this vulnerable population. Especially important are tools that have been normed for older adults, like those we've seen on consultjerry.rn.org. We know that diagnosis of psychiatric disorders is dependent upon whether or not or to what extent the symptoms interfere with normal functioning. So utilizing a functional assessment tool is very appropriate as well. In order to obtain the best results when using these screening instruments, we want to make sure that we assess our resident or our older adult at a time of day where they're feeling rested. We want to make sure that we've tended to their acute needs such as toileting. We want to make sure that they've got their sensory aids in place and that we're working on developing and establishing a relationship of rapport. We also know that it can be very helpful to access an informant like a family member to corroborate and obtain supplemental information that the older adult themselves may not be able to provide for us. Given the sometimes vague symptoms that the older adult may present, the history is a very, very important part of being able to differentiate depression from other disorders that are commonly seen late in life. In particular, a history of previous depressive episodes or a family history of depression can be associated with late depression in life. So can other diseases like cancer, heart disease, and stroke. We know that medications also have a depressive side effect, or many of them do, so we want to make sure that we do a very careful review of medications as well. Once it's detected, major depression is typically best treated with medication, often in combination with psychotherapy. The class of medications known as the SSRIs are usually recommended as first-line treatment for the older adult population, and response to these is very individualized. We need to make sure our older adult population knows that we want to keep them on these medications, if possible, for at least a 6-week trial period for us to gain an evaluation of their overall efficacy. We know that there's still question regarding long-term maintenance of antidepressant therapy, but for those individuals with recurrent episodes over time, this is still currently the preferred regimen. For those experiencing mild depression, however, the treatment of choice, at least initially, is going to be non-pharmacologic. For example, some of the different types of therapies, as well as implementing an exercise program, bright light, etc. All of these have been known to be very effective for the individual with mild depression. Excuse me a minute, that's my son. Hold on. Yep, sorry about that. That was my 14-year-old checking in on me. Anyway, I'm going to go ahead and just continue here. Um, Let's see, some special nursing issues that we need to consider for the older adult with depression. We know that it can exacerbate other disorders and result in excess disability and overall poor quality of life. We know that suicide in older adults, especially among those over the age of 75, is the highest for any age group in the United States, and that depression is the most frequently associated mental disorder. We know that older adult men especially are more likely to use firearms or other lethal means and are more likely to be successful in their suicide attempts than younger persons. We also know that very frequently older adults are far more likely to have seen their health care provider within a short period of time just prior to the suicide attempt. So, screening for depression and asking specifically about suicidal ideation is very, very important part of assessment of the older adult in any clinical setting. Fall risk assessment is very important, especially when individuals are taking tricyclic antidepressants. We know this because of the primarily common effect of postural hypotension with these medications. So the nurse needs to make sure that fall risk measures are put into place to help reduce risk of injury while maintaining mobility for this population. Substance abuse in the older adult is a common problem as well. They do suffer abuse problems, notably alcohol, tobacco, prescription drugs. We also know that there are illicit drugs such as cocaine and heroin, and that these are also increasingly becoming problematic as more heroin users are living to old age, and as the baby boomer cohort, who had a great lifetime history of substance abuse, reaches older adulthood. The DSM-4 criteria for diagnosing substance abuse and dependence is not necessarily likely and adequate to diagnose many of the older adults with these problems. So they are at an increased risk for related physical health problems and perhaps even premature death. We want to make sure that we screen for alcohol and prescription drug use for all older adults over the age of 60. And there are a couple of tools that are in place. One is the CAGE and one is the SMAST G for screening the older adults, and these tools are normed for the older adult and are available in the consultgerryrn.org website. Anyhow, whenever there is a concern, the patient should be asked directly using an approach that links worsening medical illness with alcohol or other prescription medication use in a non-accusatory, non-threatening manner. Older adults as well as adolescents may be admitted to emergency departments and med-surg units while using substances. So again, it's important for us to screen for the history of use and be alert to withdrawal symptoms. And this is very important both for the comfort of the individual and as well as to prevent any adverse events from happening. In the event of nicotine, patients who are addicted to nicotine can be offered a patch, and there are other medications that can be offered to individuals with a history of using alcohol or other substances to help make their withdrawal more comfortable and less dangerous while they're in our care in the acute care setting. We know that serious mental illness persists over time with many remissions and exacerbations over time. And we know that individuals with long-term and lifelong mental illness have special needs as they age, including the ability to cope with a myriad of new and chronic health problems and associated functional decline that occurs late in life. But because of their likely isolation from mainstream health care, people with schizophrenia, bipolar disorder, and severe depression are at greater risk of receiving no care or even poor care, despite their greater likelihood of having long-term psychiatric illness and many medical comorbidities. Patients with serious mental illness pose particular challenges on admission to general med-surg units or to nursing facilities that are of long-term nature because of their often paranoid behavior and difficulty clearly communicating their needs. So, if information can be obtained on transfer regarding the patient's normal functioning and communication patterns, the nurse is going to be in a better position to recreate a safe environment for this patient. On admission to an acute medical facility, the nurse should be aware also that older adult patients may not have been compliant while living in the community with their medication regimen. So daily dosing in the hospital on their supposed medication regimen with psychoactive drugs may actually result in an overdose. So nurses, beware and really try to get a good baseline assessment of what actually your patient was taking in the home environment. So promotion of healthy aging in all aspects is a very important role for the RN. We know that early recognition, diagnosis, and treatment of mental disorders that are common in aging is very important to prevent disability and further decline. We know that care for older adults with mental illness requires sensitivity and observation and relational skills in order to help the older person achieve and maintain the highest possible level of functioning and well-being. We want to be sure that we provide for a peaceful death in this population, and we also know that geropsychiatric nursing is both a challenging and rewarding area of nursing practice.